So I'd like to start with an overview of what I'm going to talk about today. And one is pointing out that obviously kidney disease is a very significant public health problem. And I know that your group is focused on focal segmental glomerulosclerosis and other glomerular diseases. And what I'd like to do at the beginning of the talk is put that in context of everything else that we're looking at. As with most diseases, early detection and treatment are very important. It significantly impacts on prognosis. And then I'm going to talk a little bit about how we can work together to make these things happen.
So I thought, as I said, we'd put it in context. And this data is from 2004. But you can see, if you look at the cause of the incidence of disease that gives you end-stage renal disease or kidney failure, and look at the number of patients in thousands over time, you can see, as I'm sure you've all heard on the news, that there is this increasing trend. And the trend is overall, and what I've done here is I'm showing you how it breaks out for individual disease processes. So diabetes, still the #1 cause, going up. Hypertension, right behind it. But even with glomerulonephritis and other glomerular diseases, there's been an increase, not as huge, not as marked, but it certainly is also trending upward. The other thing that I wanted to point out, as has been alluded to with FSGS, and this is not just for FSGS, but for a lot of other chronic kidney diseases as well, is that the risk of kidney failure is not uniform. We see very different risk ratios depending on the person's ethnicity. So if you compare to whites, to Caucasians, African Americans are almost 4 times as likely to have end-stage renal disease. Native Americans, twice as likely. Asians and Pacific Islanders about 1.3 times. And then because of the way the NIH tracks Hispanic as an ethnicity versus a race, because you can be Hispanic and black or Hispanic and white, this is also broken out. If you look at Hispanics compared to non-Hispanics, that risk goes up about 50%. And I wanted to show that the data that I just showed you is in adults. The same occurs in children, that there is this differential amount of kidney disease depending on race. And this data comes from NAPRTICS, which is North American Pediatric Renal Transplant Consortium study that's expanded now to not just transplants, but patients with chronic kidney disease. And if you look at the cause, the one that's of most interest to this group, focal segmental sclerosis, and the percent in all children, it's about 8%. But then when you break it down by age, the adolescent age group, since they're the ones that tend to be affected more, and race, you can see that in all 12-year-olds, it's about 12 and above. It's about 15%. But now break that down. All Caucasians, it's 5%. Caucasians 12 years and older, 8%. Look at the difference here. Black children, 12 and over, 31%. Hispanic kids, 12 and over, 17%. So again, there's this very different prevalence. The other thing I wanted to point out to you here is the cost. Now, this is way back in 2002, so you know it's even more now. In billions of dollars, this is the cost of the care for kidney failure in the U.S., $25.2 billion. Counts for 6% of Medicare payments, which is even important in children because Medicare pays for their dialysis. Lost income, $2 to $4 billion per year. This was the total NIH budget for 2002. So we're not even covering the cost of kidney failure, and the whole NIH has got to fund research in all sorts of disease processes. So I just want to, like I said, put it in context of where we're headed here. Now, one little piece of good news that I have is that in last year's USRDS, which is the United States Renal Data Source 2005 annual report, for the first time, rather than that upward going graph that I showed earlier on for the incidence of end-stage renal disease, for the very first time it looks as if things are leveling off. and maybe even decreasing a bit. However, when you break it out, that's for very specific disease processes and for very specific racial groups. I don't want to spend the time showing you all the various slides, but if you broke out diabetes, for example, that I showed you as the leading cause, if you looked at Caucasians with diabetes, then this is certainly the case. You look at Hispanics or African Americans with diabetes and end-stage renal disease, and it's still going up. They didn't level off. But in general, we seem to be making an impact on the incidence of end-stage renal disease. So what can we do together here? Just a quote from Winston Churchill, if we're together, nothing is impossible. If we're divided, all will fail. This has got to be a joint effort. The NIH, I showed you our budget. We certainly can't do it all on our own. NephCure is not big enough to do it on their own. But together and with other groups, we can probably start to make some progress. So what is the NIH doing? We're funding clinical and basic science research on glomerular disease. And as Dr. Kaplan alluded to earlier, people often wonder, well, why are you funding that and not this? And people think that the only thing we ought to be looking at are clinical trials, but you have to do the work in the lab too, and then take that information then to the clinic. It can't be just one or the other. Now, the FSGS clinical trial you're going to hear in great detail in the next talk, but just to briefly say, this is a trial for patients with steroid resistant, and you've heard that term defined, FSGS, ages 2 through 35, and we're looking at cyclosporin versus mycophenolate mofetil, otherwise known as CellCept. And Dr. Caskell is going to go into great detail about what we're doing with that trial. The other thing that we have going is a clinical study of chronic kidney disease in children. And while this is not specific to FSGS, FSGS patients are included in this study. The things that they would get out of this study that they won't get out of the trial that I just mentioned, we're going to be looking in all these children at their neurocognitive aspects, which we know are negatively impacted by chronic kidney disease, doing ambulatory blood pressure monitoring, doing echocardiograms, because heart disease in the adult population is the leading cause of death in people with kidney disease. And we know that the impact on their heart does not just start when they cross that line from age 18 to 19. It starts in childhood, and we're wanting to look at that. We have renal centers or centers of excellence that we fund. And I've only pulled out a few of them here. I didn't list all of them, but pulled out the ones that are specifically looking at glomerular disease. So there's a center at Vanderbilt that's looking at the biology of progressive nephron destruction. And you've heard about the nephron and how it's destroyed in FSGS. At the University of Michigan, there's a center looking at the biology of the glomerulopodocyte. And you're going to get a lot of information on the podocyte later today. At the University of Texas, there's a center looking at genetic and molecular mechanisms of renal disease. And we have a couple of centers of excellence in pediatric nephrology specifically. This one also at Vanderbilt, looking at fibrotic sequelae of childhood renal disease, obviously quite pertinent to the FSGS population. We also fund what we call ancillary studies. So what we look at, for example, the FSGS trial or any other trial that's going on, you may say, okay, here's a population of patients and this is the trial we're doing. Someone can come up with an idea that says, well, in the main trial, you're not looking at X or you're not looking at Y. I'd like to look at that same population and look at this aspect in a little bit more detail. And we do fund studies like that. Again, not specific to glomerular diseases, but for our studies that are in glomerular diseases, people can get extra money to do ancillary studies. And we have already funded quite a few grants for FSGS and other related glomerular diseases through this mechanism. We had a glomerular disease workshop in January of last year, of which Dr. Holtzman was a major contributor. And this consisted of basic scientists, clinical investigators, international groups. What we do when we bring people together like this is to say, let's define the problem. And what do we need to do? What is your advice to the NIH on where the research dollars need to go? And there were some very specific recommendations that came out of that meeting. One is the need to identify biomarkers. Maybe there's a way that for some of these diseases in glomerulonephritis, there are tests that you could do that would give you some information about prognosis. Maybe we'll get to the point one day where you don't necessarily need to biopsy the patient to find out what they have. Things like that we need to move along. We need to clearly define the clinical outcomes in these patients. And of course, more large multi-center trials. No one center sees enough of these patients to do the studies by themselves. We have to cooperate and do them together. There were also a number of recommendations in terms of the basic science, the work that's done in the laboratory. We have a lot of animal models. Those need to be standardized. We need to do analyses of the genetic models and do the phenotypic analyses, meaning describing what they look like, how do they present, not just the genes. There's IgA nephropathy, which you've heard can be related to FSGS. We don't have a good animal model of that. Repositories for tissues and pathology slides that as we make progress with things we can look for, we can go back to those old samples and test them and see if we can get more information. A lot of people have transgenic mice where they've adjusted the genes. And a lot of people kind of keep them to themselves. We'd like to have a process where there's greater sharing of that. We also fund what we call pilot studies, not just the huge grants and studies, but small studies to look at things. And we now have what's called a program announcement, meaning we send out a solicitation. We say to people, this is something we're interested in. We'd like to receive applications from you on this topic. And this one, we're looking for people to do basic research in glomerular disease. And this was a direct outcome of that workshop that I mentioned. We also do clinical pilot studies. You don't need to start with 1,000 patients. Maybe you can do a study in 50 patients, get some information, and then move on. There's something that's certainly pertinent to this group if you have children with chronic disease, and that's looking at self-management. When they're ready to move from the pediatrician to the internist, they've got to be able to take up some of that responsibility. And we've certainly seen in some preliminary analyses that there's how can I put it, the patient's ability to start assuming their own care and taking responsibility and knowing what their medication is when they go to the internist is lacking. We tend to coddle them in the pediatric age group, and mom and dad are keeping track of the medications and when they're supposed to be given, and there's got to be a point of transition where the child can take that over so that when they move along. There are other things we're doing. We want to get some non-invasive methods. Again, getting away from necessarily having to do a biopsy every time to make a diagnosis. Looking at disease biomarkers in the blood, or looking in terms of non-invasive methods, maybe some type of imaging method on the internet. And what that tracks, just patients on dialysis. That's for end-stage renal disease. We do not, at least through government sources, have another way of tracking. I mean, Medicare has some information, the USRDS has some information, but in terms of just general across the board, there isn't anything. The USRDS is not, for example, going to have information on people that have chronic kidney disease but have not yet reached dialysis. Okay. Yes?
Is there any type of website that we can go to or to find out information about pilot studies? If there's something coming up?
Oh, yes. I should have included that. www.niddk.nih.gov. We'll take you to the NIDDK webpage, and there's a link there called Current Initiatives that lists all the program announcements and all the requests for applications that are current, for which we're accepting applications.